Hello, ladies and gentlemen, and welcome to episode 28 of our Decoding in Healthcare series. I'm your host, Hetvisha, and I'm excited to guide you through today's fascinating discussion on AI in oncology, a field where technology is revolutionizing cancer care. And who better to explore this topic with us than today's distinguished guest? First up, we have Dr. Anjali Kulkarni. Doctor has over 23 years of experience combined in clinical oncology and healthcare technology. And she has been at the forefront of integrating AI and digital health into oncology. With her vast experience in clinical data, product development, and strategic planning, she's committed to leveraging AI to provide insights and build innovations that benefit all stakeholders in the healthcare system. Her expertise extends from clinical marketing and go on to market strategies to client engagement, making her a driving force in healthcare innovations. So welcome, Dr. Anjali, and it is a pleasure to have you.
Thank you.
In a conversation with her is Dr. Dipu Patel, a renowned digital healthcare consultant who has extensive experience in blending digital tools with clinical practices, improving the overall patient experience. So thank you, Dr. Dipu, for joining us, and welcome to the podcast.
Thank you so much, Hitvi, and thank you, Dr. Anjali Kulkarni, for joining us today. We are delighted to have you in conversation on this fascinating topic, which is near and dear to my heart. Dr. Kulkarni and I actually worked for a short period of time together, and so I'm delighted to welcome her to this podcast. Thank you to our audience for joining, and we'll dive right in if you don't mind. Dr. Kulkarni, tell us about your. We heard a little bit about your bio. Tell us about your experience in AI and digital health up until now. I do believe, if I recall correctly, you were at IBM at one point in India.
Yes. So thanks for this opportunity, and then nice to meet you, Dipu, here again. So I will just briefly touch upon. Hetvi has very kindly given an introduction. So
This meeting is being recorded.
By training, I am a radiation oncologist. So the clinical foundation comes very, it's the basic of my expertise on which I think it was built upon. And then came a little bit passion about technology. And once I went deep into the technology, I think it's equally a fascinating world. And I think that might be my message end of this podcast, that with a strong science or clinical background, with a little bit passion for technology, can help into delve into this AI world very smoothly, and I'm sure you will enjoy that ride. So when I went into a technology, and I think Dipu is also expert into a digital health technology. So I started a journey from there, and when AI came into a picture, I happened to be work with IBM Watson. There, my role was basically as a clinical adoption leader, where you take the AI technologies to the doctors, basically to the oncologist who treat patient, and see whether how they look at these AI solution. Do they believe in them, or are there any kind of different nuances required for a particular geographies? So a lot of these solutions are made sometimes in the other parts of the world, because the science and a lot of research and the technology things happen at that side. But when they come to a country like India, do all the recommendation or the AI output can be applied to our patient as is, or is there require any kind of tweaking along what we call it as a localization? And I think that that is one of the biggest, I will say, challenges, or maybe it's an interesting challenge as we go across different geographies. And that's how the AI journey started. And being privileged enough to come across, because the technology is evolving as super fast as possible. And this is AI technology, or a AI evolution is a one where clinicians also stood up and, they have embraced it very graciously, because they know there is a huge potential into their day-to-day practice, or might be in the clinical care, in the patient care.
Yeah, absolutely. And I couldn't agree with you more. And I think, our journeys kind of mimic each other in terms of our interest and passion into technology. Because the more I read about it, the more interested I got, the more fascinating it was for me. And I think AI just kind of adds another layer of curiosity for me. And so I've definitely drank the Kool-Aid, I guess, so to speak, and I'm all in at this point. So, in terms of clinical practice, you mentioned that you are a clinical adoption person. What are some of the AI tools that you are seeing being used currently in oncology practice or rad-onc practices that you're seeing? And I totally understand that there are differences among countries because of regulatory measures. But where you are in India, what AI tools are you seeing being used in practice?
Yeah. So currently there are, plethora of AI solutions which are even coming to India at many stages. Some of them are in the pilot stages. Some of them have passed the FDA approval and they come to our clinician directly for use. So many solutions, and very interestingly, even many solutions are getting built in AI, built in cancer care from India. So the overall opportunities are immense. And as of today in the clinical practice, so currently I have just shifted on towards a little bit of precision medicine, being a radonc, and then, recently joined a genomic startup. So the journey there is how we can give a best personalized or a precision based protocol to a patient. As we all know, cancer is a very complex disease, and the whole genomic profiling of a patient, which few years back thought to be a complex test to be done. Nowadays, I think it's more easily available, accessible, and affordable even in countries like India. So we are having a genomic profiling done for a patients, where the patient either they don't respond to a treatment, or they become advanced during their cancer treatment, or there are many young patients who would like to know the best treatment possible at the diagnosis or at the onset itself. So in that case, one of the very interesting tools, or a very interesting AI solution we are using, where there is it's from a company called Cellworks, and where they use a computational biology platform, or a computational simulation platform, where a patient genomic profiling is taken, and then they run through a different pathway simulation, and at the same time different drug database, and try to find, with the help of AI, what is the best treatment combination for that patient. So traditionally, we all know in oncology, we are all protocol driven. There is evidence-based medicine practice, and we know NCCN guidelines, we know ESMO guidelines, ASCO guidelines. There are many other guidelines which are followed. But I think AI is breaking way through that. Of course, the guidelines are required, but there can be something more insightful for an oncologist, uh, where he can get added insights from the patient profiling, and there can be a too personalized treatment protocol for that particular patient. And this report, which is a AI generated report, where they give different treatment recommendation, is we are using it very routinely. So whenever a patient comes for an advanced genomic test, along with that test report, his biomarker profile, mutation profile, this will be additional report where what kind of drug are best suited for that kind of a mutation. And I think such more and more solutions are coming forward, and they will have a great advantage to a clinician to get insight. And if the patient responds, I think it will be a great advantage for a patient also.
Absolutely. And for our non-oncology folks, what Dr. Kulkarni is mentioning here is we've historically had some cancer and tumor markers that we can kind of target certain treatments towards. So think BRCA and KRAS and EGFR and all of these kinds of things. The problem with those is that they're targeted to a tumor specific, right? Those are markers on the tumor. What she's talking about is actually genetically profiling each individual and then targeting the cancer to treatment specifically to that, which also helps in terms of decreasing side effects and adverse effects of various chemotherapy regimens, because it's not just a singular medication or a singular biologic or immunologic that we're giving. We're usually giving a cocktail of chemotherapy regimens. And so you can see where understanding and having a deeper understanding of your genomic profile, and then in addition to the tumor markers as well, but can really help provide that targeted treatment. And we are closer, I think, in oncology to precision medicine than we've ever been. Would you agree,
Absolutely.
Dr.? Yeah.
Yes, absolutely.
Yeah, and I think the thing is, what we're seeing now is more and more studies that are using AI to kind of target this sort of treatment. And once we have full-on validation of these models, we're going to be implementing them into practice probably faster. And I will say, I've worked in the ER, I've worked in oncology. Nowhere have I seen oncology have I seen evidence-based medicine practiced into its most current form. And oncology, I mean, the regimens, the guidelines we have can often change on a weekly basis because there are new studies coming out. And so you add AI to the mix of this and how we're really targeting and focusing our personalized treatments to not only the type of cancer or the stage of cancer, but to the human being that we're seeing. And that is truly watching personalized and precision medicine come to life. So you had you mentioned about so a couple of applications. I'm drawing a blank on the one you just said, Selva. I think you said about promising applications that make a difference on patient outcomes. Are there specific cancers that you're seeing this in, or is it across the board that you're seeing it? Are solids, liquids, like what are we seeing most progress on right now?
Yeah, so I think these are getting developed across all tumor types, and currently different solid and hematological malignancies are being covered. So currently, though there are a lot of AI applications which are in the diagnostic side are getting built up for the solid tumors, but I'm sure hematological malignancies will not be left behind, and surely
I'm sure
there will be some very, very promising applications coming our way. Sometimes hematological malignancies happen in the very young age group, childhood, and I'm sure we would like to offer the best of diagnostic and the treatment options to the younger patient population into cancer care. And
absolutely.
yeah.
Your background is in radiation oncology, and one of the areas that we've seen the most explosion in is radiologic imaging, right?
Exactly.
How do you see that impacting cancer care, such as treatment and planning or follow-up of patient care?
Yes, so the interesting thing about radiation oncology is a lot of all treatment planning is depend upon the imaging. So you see a tumor on a CT scan, MRI, or a PET CT, and then you identify the tumor. But at the same time, you identify the organs at risk. Suppose it's a lung tumor, you immediately try to identify if it's a left-sided lung tumor, where is the heart and where are the other normal structure, and you would like to save them. So what we used to call is a tumor segmentation used to be a very manual, a process used to take a lot of time, and sometimes there used to be a small margin of error when we do it manually. But currently there are very good AI algorithms have come up which quickly help you do the automatic segmentation of a tumor, and same time these multiple organs at risk. There will be spinal cord in the back, there will be heart, and there might be, a little up there might be esophageal, thoracic esophagus might get the extra dose and things like that. So these AI-based segmentation tools will help the clinician quickly segment almost all of the structure, and he can go and fine tune wherever he thinks AI has not done the great job. So even this can help to optimize the toxicity, as Dipu mentioned very previous in the prior talk, that it's not only about giving the best treatment, but it's about reducing the patient toxicity, which is equally important. And especially in the radiation, because radiation is, it's a prolonged treatment. That radiation treatment goes on for 4 to 6 weeks. So taking the patient all along through radiation treatment with a good quality of life is equally important. So in that cases, such tools are coming out to be a great helpful for a radiation oncologist or dosimetrist. Same time, I think the another very interesting branch and audience should go ahead and read about is a radiomics. So all this time we used to see just a, I will say 2D, 3D grayscale image, or, a Hounsfield spectrum onto a radiology images. But now very many algorithms have come forward where we can do some kind of a texture-based analysis. We can run different kind of algorithm on the tumor segment and run some kind of, added algorithm on top of it, or build models on top of it. And there are, few algorithm which can predict that this kind of a texture with this kind of pixel distribution might turn out to be an aggressive tumor, or such kind of a tumor might not be very aggressive, or they will respond to a treatment. So it's not only about tumor segmentation, it's doing some kind of radiation plus omics analysis, and then that will help us to either do the dose escalation, or we can predict toxicity, and same can even we can predict the treatment response. So radiomics is again a very, very promising. Personally, I like, I find it very fascinating. And there are very good AI models have come up, and some of them are very close to clinical use. People have published a lot of literature, but we all say that literature is a very controlled based clinical select paper patient population. So when it goes out there in the real world, we will see what kind of performance or the result it will give. But I think this is again one of the very interesting application of AI application coming up in the field of radiology or radiation oncology.
That's really fascinating, because what you're talking about is really targeting and fine-tuning dosing of radiation depending on the kind of tumor, the density of the tumor, and the presentation of the tumor, so that you are not over radiating, because we all know that this can have adverse effects down the line, but also maximizing the treatment potential. So you're not, so to speak, zapping something more that should be zapped. You're kind of, radiating it at the right precision point, and you're not over radiating it to minimize these adverse effects, if I'm reading you correctly here.
Yes.
Yeah, that's amazing. And so we've, as clinicians are adopting this, I mean, as I'm very excited about this field, because I really do think that AI is going to change how we deliver cancer care for better outcomes and better survival rates. How are patients accepting this journey? Are you finding them to be more trustful and understanding of including AI into the decision-making for their care?
So my experience will be for our patients from this part of the world, from India, where I do my work. So here at least patients are not still, I think they are still following whatever their treating physician says. And currently, it's everything is physician driven or a clinician or an oncologist driven, right? But I will give you an example of when we had IBM Watson rolled out, and there were people who will read up on the internet, and they were very enthusiastic about what is it about, at least to know about what kind of AI tool this is and what kind of treatment recommendation it gives. But that was a very, very super select of patient population, I will say. And especially in country like India, this patient population is where they come to a private hospitals, not so much into a public hospital where, the different kind of healthcare literacy matters here. And in that case, if the treating physician has some tool, I think he himself is completely confident about that AI tool, and he goes back and explain to the patient how this tool is helping him to take better decision. And I'm sure there will be a few select patient population who will adopt, or if at all they have to pay extra for that kind of AI solution, they will go ahead and pay for it. But as of today, we are not there anywhere. I think directly patient coming forward and asking for any such kind of a solution. I think we are still a long way to go, at least in India.
I would concur with that from the US side as well. I think patients are, especially with cancer care, and maybe in other areas, they will ask for AI or come to you as a clinician with AI tools that they're using. But in cancer care, I'm finding it's a bit of a mixed bag. There are clinicians who are adopting it and offering it to their patients, but it's not fully rolled out. Usually it's in a very, it tends to be at these large academic centers where there's ongoing research in the area. And so at this point, I'm not seeing patients asking for it or demanding it, but they are happily actually accepting of it when it is offered to them, whether it be in the context of a clinical trial or a pilot that a hospital is running. So I do think that this will become more and more the norm for us. And it's really helpful to add to the research so that we can validate all of these algorithms so that they're ready for public consumption, or prime time, yes, as I would say. So we're not quite, I agree, we're not quite there yet. But I think it's very promising. And definitely, I think in both of our lifetimes, we will see it come to fruition and use for practice. So you've been working in this space for a while, and you had mentioned earlier that you were part of the clinical adoption team. What were some of the biggest challenges that you faced in integrating AI into clinical workflows in oncology?
So the one of the biggest challenges, of course, come from a clinician. So as long as they don't find it, they don't confide in the solution completely, they will not adopt it. And a lot of clinicians don't like to suppose there is some solution only for a particular select group of tumors. Suppose we developed a solution only for, say, breast, lung, colorectal, and not relevant for the other thing. So somehow clinician want to get everything possible into oncology into that AI solution, which is a very, very unrealistic situation, and it's very difficult to very difficult to convince them. So I think the first thing is we have to first find out what is actual gap in the clinical care. So is the gap is about meeting out the recommendation in the complex cancer care, or is it about too many protocols or too many recommendations are coming forward and they're not able to keep pace with that and things like that. So I think we have to lay out and do some kind of a physician or a treating or a oncologist profiling has to be done. And then we select particular a group of a clinician whom we can call it as early adopters or a kind of key opinion leader. And then once they are convinced and they see value in that, I think that solution will get adopted. So the solution maker has to take that pain. I think they have to go through, they should have a patience, and it has to be a limited usage in a very, very focused group of patients. And we see the output, we see the clinical relevance. That is one challenge we saw. We just can't put some solution, implement in the clinic, and we say start using for tomorrow. That is never going to happen in AI.
I
The
don't think
second
it would
one,
happen. It wouldn't happen in any environment, actually, when it comes to
that's
clinical
true.
practice.
The second one, I think it has to be seamless in their workflow, right? We cannot put some another system out of their EMR desktop and a laptop and say that AI system exists here and this is your EMR. So we have to map it to the whole clinical journey of a patient and make sure that it can be a diagnostic AI tool, or it can be a treatment recommendation system where they are trying to see, what is the best treatment or anything. So it has to be seamlessly come in their workflow. It should be available at their point of care, in their EMR as a module or anywhere, any kind of a use case. And I think then there will be a less, less confrontation with the clinician, and they will be able to at least look at it, and they will be able to use it. So these two were the main challenges which we saw, that not actually going seamless with the existing workflow, and the second one is not setting the expectation right from that particular solution, where we will require some kind of physician training to start with,
I would
when they
agree.
start using AI
Yeah,
solution.
you call it a key leader. I would say a champion, someone who
Yeah.
really wants to integrate this into their workflow. Because you're right, I don't need in my day one more login and password to remember to
Right.
use a system for the 2 patients that I'm going to have on my schedule who will qualify for this particular AI system. So I completely agree. And then that has been my experience as well. Stakeholder engagement, finding those champions in the practice and getting the buy-in from the clinician. I mean, leadership can say, yes, we're going to use this, but if it doesn't mean anything if the clinician who is on the ground seeing patients does not actually utilize the technology. And so if you're going to invest in technology, I would say, and I think you and I both have very similar experiences around this, which is if you're as a leader, as a hospital association, you're going to invest in a piece of technology, make sure you have buy-in from your clinicians who are going to be using it, because there are a lot of old tech. There's a lot of old tech that is loaded onto computers that never get used because it's too cumbersome and does not fit into the workflow.
Right. Yeah.
I would
especially oncologists are all super specialized, right?
Yes.
They themselves are experts in everything. So offering them something which is a real value add to their workflow, I think it has to be well thought through. So there has to be a plan. There has to be adoption plan for every clinician, for every hospital. First, there has to be a mapping of the workflow, mapping of all the users into an ecosystem. So lot of time the junior doctor enters the notes, right? So whether he's putting the right keyword, is staging properly, and then suppose you have an NLP system into your AI solution, whether that word get caught and then your AI system get triggered or not. So everything has to be well thought through, and it cannot be that the solutions are made in the engineering lab and the clinician sits in the hospital. They have to be co-created. So that's how I think co-creation word came in the clinical AI space. There we have to sit with doctors, and then at least from a very early on, we have to start doing this. Even a building UI UX has to be with the help of a clinician.
Absolutely. I would absolutely agree with that. So as you see oncology evolve, we've touched upon some of these things. What do you think the next decade of AI is going to advance for us in oncology? So you've talked about radiomics, we've talked about algorithms. What do you see next?
I think this foundational model or a foundational thing will get more and more mature. And the current era is of a multi-omics data, right? So there will be clinical data, which is in the form of a text. There will be imaging data, which is from radiology image. There will be pathology images from a digital pathology, and then there will be genomic data, there will be proteomic data, there will be transcriptome data. People are talking about day-to-day wearable data because that's where the real-time activity happens with the patient. And if he is having any kind of adverse event, toxicity, any outcome is always happens in the real world. When the patient goes home after taking treatment, what kind of events happen in his day-to-day life? Does his blood sugar fluctuate? Is BP dropping? That might be a reason of some chemo drug which he has taken last week or a immunotherapy. So I think all this multi-omics, multi-dimensional data, and in oncology, this is more of a longitudinal data. So since the patient get diagnosed, or even there is a suspicion of something going wrong, till his survival, everything is very, very relevant in oncology. So longitudinal, multidimensional, multiomics data is a way forward, and I'm sure the next decade will be combining all this data together, making sense, and then extrapolating things from one thing to other. So people are just looking at a simple digital pathology images. So they are thinking, should I even do a NGS test? Can some of the features here along with the machine learning tell me that, this patient will be probably having this kind of a biomarker or a mutation profile, and I can just take a decision based on that, because everybody might not have access to NGS test, or they might not be able to afford it. So I think extrapolating data from one of the modalities, like radiomics is doing, like that, there is histogenomics is coming up and things like that. So making sense from all this data, because that all belong to a single patient, and it's a single disease journey, and then making sense, building model, and same time building a predictive or a prognostic indicator very early on, right? It should not that we give the treatment and then we wait whether the patient responds or whether he comes back in 3 months with a disease, or a 6 month or 3 years. Can we build something, or can we at least predict something very early on, and then keep the patient on a close follow? Or even we can stratify the patient as treatment responders, not responder, or a high risk or a low risk. And then after stratification, we can keep them on a different follow-up protocols. I think these kind of things will be more evolving going further, and which will be truly a precision or a personalized protocol. Now every patient comes at the 6 week follow-up, then he comes at 3 months, 6 months, 1 year. Whatever happens in between, if he's doing well, he doesn't come back. And if he gets a problem, he immediately runs to the oncologist office, things like that. So people are thinking, can I put this patient on a telemedicine surveillance or a follow? Because he is from a low risk. He's doing well. I think he will respond to a particular immunotherapy, and he can have a better quality of life, and just keep sending me the relevant clinical or hematological markers, and I know he's doing well, things like that. So I think that's going to be the future, where all different types of data woven together, and they will make a sense, and people will come very, very collaboratively closer. So clinician, I'm sure, will become a part data scientist, and a data scientist will become a part domain expert, and will have enough clinical knowledge. I think there will be not very sharp boundaries. People will work very collaboratively together in a patient care. I think that is going to be a future for oncology care.
I couldn't agree more. Actually, you took the words right out of my collaboration. Collaboration not only within the discipline, but across disciplines. And I think one of the bigger fears from an industry perspective is AI going to take my job? And I think you have very nicely outlined that it's not actually. It's going to enhance your job, and in fact, it's going to make new roles that are going to be even more important to be part of this collaborative team to care for a patient. You've probably listed 5 or 6 roles that are going to be created because of this particular tool or technology. And so I find that very promising, because in my experience working in oncology, it's a naturally collaborative specialty, right? It's med-onc and rad-onc and surgical onc. Like you're talking to each other across within the discipline, but across the disciplines, right? I think you were gonna, as you said, the lines are going to get blurrier as we start adding data scientists and genetic counselors and population health managers and telemedicine into the mix. So I think I couldn't agree with you more. I think the multimodal approach to patient care, and in fact, I think other specialties are going to learn from the collaborative nature of oncology. Not to say that they're not right now, but I think the close-knitness that I've seen in my own practice in oncology is that collaborative nature of every surgeon, radiologist, and med-onc knows the patient and knows them to the point where they know exactly where they are in their treatment. That's going to get even better, and that will lead to better patient care and better patient outcomes. And I love that you said about predicting outcomes and predicting survival rates even before we initiate treatment. That's amazing, because normally right now for our non-oncology audience, you have a stage and that we typically can give you a range of overall survival rates, or but it's not finite, right? Like it's based on a lot of data that is not necessarily precise to your particular genome or your particular area of the country. And we're going to see more of that fine tuning of the data, I think, and yeah. So in terms of, I'd love to continue this conversation about the cross collaboration, right? The collaboration between data scientists and technology. You made an important point about working on teams with data scientists and other scientists with healthcare and that blurring. Are there other areas that you see that happening in and us leveraging it as healthcare providers? Because you're right, some of their knowledge is going to bleed into our work and our knowledge is going to bleed into their work. And it's important to have that. So as companies start thinking about developing platforms to further oncology care, one of the things that, and you and I have talked about this in the past, which is, if you don't have a clinician on your team and you're providing medical care, you're a tech company. When you have a clinician, then you're a healthcare tech company. That's the difference, right? Because you need that expertise. I'm not an engineer, but I rely on the engineer to say what is doable and what isn't, right? And vice versa. Right. So can you speak to that a little bit more?
Yes, so in fact, I keep telling the young doctors now. So this is being a clinician is a most sweet spot in the current world, because you can pivot from any side currently. So you can even ride the technology wave. So I will tell audience a very interesting story. When we developed a AI solution and I gave for validation to my engineering team, they didn't know what is stage 1, what is stage 2, and they completely messed up the output of AI when they were doing validation. And that clicked me. I said the oncologist is the right person actually to validate the output of this AI solution. So I had to request few of the senior oncologists sit next to them because they were very busy, and then just run the algorithm through them, and they were telling this is correct, this is not correct, and I personally was marking that. And we did this exercise across many oncologists, across many iterations, and then we got whatever we wanted, a particular sensitivity or specificity, what we thought for. So the clinician can play a very crucial role currently in this AI in this AI revolution, especially with the clinical application, because you are the one who will be acting like a gatekeeper, that this has passed this validation test and this can go at least to a beta site for a further kind of testing with the patient with a very controlled environment. And same time, you can be at a product definition stage also, which a lot of companies had already started doing in med device and things like that. but doing a very thorough validation has to be done by a clinician. A part of it. Of course, the technical validation will be done by a technical team. So in that case, I think a lot of even young clinicians are quite tech savvy. I think you can go ahead, and most of the solutions nowadays are low code, no code, and they're quite friendly. I myself could learn few of the basic where I can, tell people what to do out of it, or what kind of validation is expected, or what kind of results are expected. So I think even for us, from a healthcare or from a domain expertise, a little bit extra technology knowledge will help us to go further. And it's very exciting when you yourself do some kind of validation, and then you see what is a report and what's the output, and how you can make it better. So that way, you can give back to a product development team a very, very significant feedback where they can improve, fine tune their algorithm, and come to a desired output out of that solution. So I think that's the way forward, and go and don't feel fearful of technology, embrace the technology.
Yeah,
and
absolutely. Yeah, well,
uh,
and that leads me to my next question, which is what tips and tricks do you have for this next generation of clinicians or technologists? I mean, don't have to be in healthcare to work in healthcare. And so, are there areas that you think is really helpful to start? I mean, I will speak for myself. I'm definitely a low code, no code kind of person. I'm not technical at all. I have no coding experience, but I can speak to the output of it, right? The outcome, like
exactly.
how accurate is it? Does it need to be, I can't tell you how to fine tune it, but I can tell you that it needs to be fine tuned, right?
Yes.
And that it hasn't hit the mark. So what tips do you have for this generation? I mean, and I will say that this younger generation, definitely a lot more tech savvy. I will speak for myself than I am. For me, it was a learned skill. I think for them, it'll be a very native skill. What tips do you have for them?
The first tip is we should never, try to do the job of a technical. We are a domain people, we are clinical people. So our skill set is our strong domain knowledge, and we know what is a use case of that application, and what is the expected output, and what can be the input. Suppose you are working on some kind of imaging, and this algorithm is meant for a X-ray. Suppose there is a solitary nodule on the X-ray, whether it's a tubercular nodule, whether it's a pneumonitis nodule, or where it's a cancerous nodule. So once you understood this application, your job is just to select a very good quality X-rays, and not select X-rays which are of where there is no nice lung shadows, or abdominal X-rays and things like that. And you should be able to quantify the report, whichever. Of course, there will be a ground truth with each, right? So my first tip is, let's not cross over to the technology side. We remain clinical people, but we learn little bit about technology and how we can help to develop the solution in a better way, and make sure they are completely validated in a true clinical sense, because they will get used into a patient care, if not today, sometime in the future, right? So the first thing is, let's not learn any coding or anything like that if you are not interested. Of course, if you are interested, you can go ahead. But people like Dipu and me will just, stop, just understand what the technical people are doing, and we can guide them. The chest nodule, when it is more than 3 to 4 centimeter, it might require a different views, AP X-ray, a lateral X-ray, or multiple X-rays, things like that. That kind of domain knowledge should, we should be able to look at the solution from that side. And I think that kind of, I will say, that kind of thought process, we should be trying to look at the solution, very critically. Second one, sometimes we can read up little bit into a technical thing about what algorithm, what goes. In fact, lot of papers in AI are very nice. Matlab, if we read it, we understand what is the training data, what is the test data, how the data sets are selected, how to remove the bias in the data sets, how can be a diverse data set, what is a responsible AI, what is ethical AI, and things like that. What are the regulatory requirements for a AI solution into healthcare? So what are the FDA approval process looks into? Things like that. That will make us AI specialist clinician. So we
Yeah,
will have knowledge about overall solutioning till from the development it comes into a market and goes into a patient use. So my tip is just keep reading and then slowly you will find your way, right? You find whether you are only clinical or these all things feel boring to you, or you can go ahead and learn a little bit more about technology side and participate in validation or participate in the product requirement and things like that.
absolutely. I agree. I think no knowledge in this space is going to go wasted if you take an area and you're interested in it and run with it, because it's definitely going to help in some way, shape, or form. I would absolutely agree with that. So we have a couple of questions from our audience as we wrap up here.
Great.
One question is, since cancer involves mutations in cancer-causing genes, how is AI being used to analyze genetic mutations and tailor more personalized treatments for patients?
Yes. So if you see a genetic mutation, and then if you go to a very, very so I'll just go to the little basics. So when we do a genetic mutation profiling for a patient, there are a lot of raw files get generated out of the NGS machine, right? These are called FASTQ files. These are called VCF files and things like that. So it's a very difficult for a human being to find any pattern in those mutations across if you have a large amount of data. And then these datas are all kind of a codified data, right? It's not a nice clinical report which the clinician get in the hand, which is all English, right? So otherwise the genomic files are very, very codified kind of a thing. So the AI will help when you have a huge amount of genetic files with you. You want to find out some kind of novelty or a novel mutation which is not found out from the literature before, or you find out some pattern. Suppose you have 10,000 breast cancer genomic files, and then you want to know, is there some pattern between the Indian women population and then the population from Europe and then from Africa and things like that, right? So AI will help you to, when you have a large amount of data and it's humanly not possible to look into data, make sense of it, find some pattern, find some or build something on top of it, or some kind of solutioning you are looking forward, and you want to find similarities of a data. So all this very, very intensive mathematical kind of a work, I think AI will be able to help you do that.
Absolutely. It's kind of like finding the needle in the haystack, right? Really making sure
Yes.
that it can read faster, process faster than we can. And that's why that's what makes AI a tool. It is not a substitute for our clinical decision making, but it is going to assist us in surfacing information that is relevant to the patient in front of us. Or the population that we are serving, right? And so that's how you can leverage it as a tool. Our last question is kind of a two-parter. How does AI assist you in making treatment decisions for complex cancer cases? And then in what ways has AI improved patient safety in oncology practice? I think they're kind of together, they're related in some way, actually.
So there is real twist in the complex cases, right?
Yeah.
So what happens, lot of time AI solutions are built using data, right? So you see 1,000 cancer patients and then you build some kind of pattern and then you train the data and get the output, right? So sometimes there might be a challenge coming up into a complex cancer cases because the overall data to work on or build a model will be very limited, right? But there are different tools coming up where people are talking about building a very ethical synthetic data where you build the data using a lot of parameters and try to build a model. But again, people say building model on synthetic data, how to validate in a real situation. So in sometimes I think complex cancer cases, it's still a challenge, but I'm sure technology or a clinical thought process will solve it very soon. But as of today, I think people are still looking at how to, address that issue about the paucity of data there.
Yeah.
The second question you were asking, Dipu, second question I missed.
It's about patient safety, improved patient safety.
Patient safety. I'm sure, yeah, I think patient safety will go a long way because when I said, so there was a very, very early example. I think now it's very, looks to be very primitive when we have evolutionized so much in AI. But people used to say that when you do a CT scan and then suppose you do a MRI of a body and then you did MRI for a chest lesion and but you have done a whole body MRI. So usually radiologists used to look at the chest region because the whole clinical indication was finding some chest mass. But there used to be a small unidentified aneurysm in the brain and which might be at a very critical stage and it might explode. We all know aneurysms are again one of those a lot of people carry aneurysm throughout their life without any problem, but few of them unfortunately then might end up in hemorrhagic stroke. So things like AI might find it out when they just do the scanning and they can alert the radiologist. So are you missing out this 5 mm aneurysm, which is at this critical, position in the brain and things like that. So there, I think it is added value to a patient safety where humanly sometimes there might be a chance of missing out and the AI solution are like mechanistically they will scroll through and give you some alert indication where clinician can have a second look. And again, when there are a lot of patient, one of the things which we were thinking was through the AI, can there be a very, very effective patient triaging system? So instead of patient being waiting down when they have a very, very suppose very critical biochemical parameter and that patient might not have to come back at a prescribed follow-up period. He might come up early because there is something built in which has seen that value triggered and things like that. So we can build a lot of basic clinical thresholds. It might not be real AI, but it might be to start with like automating the workflows, and then we can surely build AI where they will predict that this patient is going into renal failure and send him back to avoid any chemo related toxicity and things like that. So I think patient safety will be there at heart of it, of course, in any time. The patient safety can be just not only the life-threatening, but it can be just reducing the overall toxicities into oncology care and having a better outcome for a patient, better compliance, and then giving him a better quality of life.
Absolutely. On that note, better quality of life. I want to thank you for taking time out of your day to join us in this important and insightful conversation that we've had. I want to thank our audience for joining. We're going to wrap it up for today. We will be announcing our next episode soon, so stay tuned for more episodes as we move along into the holiday season. Hithi, I'll hand it over to you.
Yes, thank you, Dipu. And thank you so much, Dr. Anjali, for sharing your insights and thought-provoking conversation. And also, it is so clear that AI is not only enhancing cancer treatment, but also research and patient care. So it was so amazing to hear your thoughts on it. And to our audience, thank you for your participation and your engagement today with your insightful questions. Your questions and interest makes these sessions even more valuable. So with that, we will come up with the next Decoding an AI series soon, and it will be shortly announced. So thank you so much and stay tuned. So until next time, take care of your health.
Take care. Thank you.
Thank you.
Thank you. Bye-bye.